The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Okay, welcome everyone to another episode of the Success in Practice podcast. Today I'm joined by Elissa O'Brien. Elissa is an osteopath and a mother of two girls. She operates out of Atrium Osteopathy in Ringwood and North Balwyn, Victoria. She studied at Victoria University and since graduating has completed many postgraduate courses including osteopathy in the cranial field fundamentals, the face, pediatrics, visceral techniques, and the rule of the artery. She has also been lucky enough to lecture at the universities, at private teaching faculties, and to present at international conferences. She's lectured about the osteopathic approach to tongue tie and stress and the mother-baby dyad to osteopaths and other health professionals. Elissa makes a point in educating her patients about the disease model of medicine versus the health model of medicine, and she works at striking a great balance between the models to give her patients the best outcomes. Elissa, welcome to the podcast. Thanks for joining me today.
Hi, Sammy. Thanks for having me on.
It's a pleasure. I'm glad we've been able to do this and to kickstart the podcast. I want to know a little bit about you. I want to know a little bit about your backstory. Tell us about you growing up and what kind of got you into osteopathy.
Yeah, I grew up in country Victoria. I noticed listening to a lot of your other people on your podcast that quite a few country kids have moved into the city and become osteopaths. And I think when I think about my childhood, I grew up with a single mum and a dad that lived 8 hours drive away. So most of the time was spent with my mum in a little town called Millawa, which is where Brown Brothers Winery is. And just a tiny little town, and at my primary school, 36 kids in total at the school. So, a lot of freedom and a lot of adventure. And when I got older, I was riding horses and people would go to boarding school and I didn't go to boarding school. So their horses would be left unattended and I'd be able to borrow a horse and put it in the paddock behind my house. I grew up on an acre. So I had a lot of freedom and really, mum knew I was pretty safe. So I, could just have great adventures. And that actually led me to falling off a horse at 15, injuring my knee and getting a concussion and then needing some help. And in a country town, that's pretty hard to get. So we went to physios and orthopedic surgeons, didn't need surgery. I actually got my foot stuck in the stirrup and the horse fell into a hole and bounced back up and I knocked myself out on its neck. So it was a pretty spectacular fall and no real structural damage to the knee, basically soft tissue stuff. But it was really
Sounds
weak.
Like you got off easy.
Got off easy, but it was really weak and needed some rehab. The local physio didn't really have a diagnosis and ended up telling my mum that I needed to see a psychologist back then. So I'm 15, so, 1990 or so. And then we found...
A psychologist?
Yeah, psychologist, yeah.
They didn't see that there was something wrong with your knee, a swollen knee or something that was...
They just couldn't get it better. They just couldn't get it better. It just kept collapsing and just no diagnosis. So I found an old footy trainer over in Shepparton. So it's about an hour and a half drive. And he called himself an osteo, but I don't know what he was, but he was an old guy at a footy training place and he would just really hurt the ligaments at the back of my knee and the tendons, and I'd go and get this really full-on treatment and then get driven back home and ice it for a day or so. And he told me that he was unwinding the tendons. So that was interesting. I then tried a myotherapist, and I tried had a family friend who was a chiropractor as well. And the common theme with all of them was, if I could choose again, I'd choose osteopathy. The thing is, there was no actual osteopath in Wangaratta or Shepparton or Millawa at the time. So I went to the careers counsellor at school, and no one had heard of osteopathy. So he had to actually ring the university and find out what osteopathy was. And so a bit like you, Sammy, you hadn't really had much to do with osteo. And I had seen this guy in a back shed somewhere who called himself an osteo. But everybody just said it was a pretty amazing thing and very holistic, and that I should read about it. And so I kind of ended up just moving to Melbourne and doing osteo.
Yeah, right. And I guess what was that like? What was that first day like for you when you started? I mean, what got you hooked? Like, was it straight away? Was it love at first sight, or did did it take you a bit of time to warm up to it?
Yeah, I've been laughing about your memories of your first day, and it was pretty much the same. And I wonder what it's like at uni now. But you turned up, and we actually Vic Uni started in St Albans, which was a western suburb of Melbourne. And I basically moved down and moved out of home. And my mum actually, in the line to enrol for the course, my mum found this guy and said, "Oh, are you doing osteo as well?" And he was, and we basically shared an apartment together in St Albans, which was a, pretty western suburb of Melbourne. So for a country girl to move down into that straight away was an adventure. But yeah, like you, we ended up with, maybe 40 people I think it was even a portable back then. It wasn't a really well set up uni at that stage. And it's pretty much get to know each other and surface anatomy, and you're going to spend a lot of time in your underwear for the next few years. So that was pretty daunting, actually.
Yeah. It is pretty daunting because, it's, I guess, it's not about country life, but I guess going from family life to that kind of thing was all right. Like, let's get your gear off. And I think things changed a lot post-COVID. Like, I know with my clinic, patients used to come in, they'd be a gown, they'd get undressed and they'd put the gown on. They'd stay in their underwear, but they put the gown on top, and you'd come in, you assess them, and, you do your work. All of my patients don't get undressed anymore. You kind of just lift the shirt up a little bit, or if you need to pull the pants down a little bit, and you kind of work through clothes, and, you do myofascial work that's a bit more deeper. And I guess if you have to move something, you just move clothes out of the way. But I don't even think we use gowns anymore. Like, patients just don't. But it's amazing how things have changed. Back in those days, if you were getting treatment, whether it's be osteopathic or chiropractic or physio or massage, it was just kind of like assume that you're going to get your gear off and just get down to your underwear.
Yeah, it really has changed.
I think that's changed a lot now.
I think it's changed. I'm not sure it's just COVID. I think it's probably just... Do you think it's also us being more experienced in practice, and we know what to look for? So, as you say, we're looking at maybe the body part that they want us to look at more than the whole of them. But I do wonder about skin and skin conditions and things like that I used to be really aware of, and now I suppose there's more awareness of that, and there's more skin clinics. So, that'd be the other reason that we were taught at uni, to get people to take their clothes off so that we can see their skin. But as you say, we can look locally and probably get what we need.
Yeah, like, you're right. I think having a look at the tissue texture, I guess, and the tissue presentation is important. One thing I always didn't like is having a barrier between, like, an oil or sorbeline or something between my hands and the patient. And so I don't like having that there. And you just want kind of, if I'm going to touch somebody's skin, I just want skin on skin contact. And I guess, I don't know, I just don't need to have the whole thing off. I'm happy to kind of have a feel of thoracolumbar. I can just move the t-shirt up a little bit. If I need to have a look at, if I need to get the PSISs, I can kind of pull the shorts down, just have a feel of that. And if you're feeling anywhere else around the pelvis or usually even if they're gowns are on and their gears off, usually draping them with a towel anyway. So
Yeah.
you're kind of going through the towel as well. So it's just the way that I practice. But there's probably people out there that are still doing that. Sorbelling and oil and deep myofascial work and things like that. But
I think I've always been mindful.
So going back to
that.
your
I've been mindful of covering.
Going back to your,
I think it's important. Sorry.
It's very important. That was drilled into us in like the first week of osteopathy at university. It was actually Peter Edwards, he was a British trained osteopath, and if he saw you not draping, the person you were working on, and that was your fellow student, with a towel, he'd be like all over you and just like, you got to drape him with a towel.
Yes.
And so, but anyway, going back to your experience at university, you were the first cohort through at Victoria University. You were the first year that they taught osteopathy. And I guess, tell us what that was like. What was that? I was the second year through. So, we kind of had a similar experience. That there's a lot of teething problems. They kind of get to it. They might get the cervicals and say, oh, shit, we're teaching them cervicals. We haven't actually taught them the anatomy. Let's hurry up and do a crash course in cervical anatomy. But teething problems, I guess you guys trying to work out what to do, and that combined with the excitement, I guess, and the adventure of starting something new. Tell us what that experience was like.
Yeah, I think not knowing anything about the profession coming in, I actually did apply for RMIT Osteo, and we had interviews at that stage. And I remember going into the RMIT interview, and the person who interviewed me didn't like me, just didn't like the look of me or something like that, and basically told me in the interview that I wasn't going to get into RMIT. And so I was thinking of other options. And then we got, I suppose everybody who'd applied for RMIT got a mail out that VU was opening a course as well. And so I applied and interviewed there, and the people who interviewed me there just loved me and just straight away said, absolutely, you'll make a great osteopath. I think the interview that went badly was because I hadn't had the awareness of osteopathy, and I kind of did go in, a little bit country girl, relaxed. I love this profession. It sounds really good. And when they asked me why, it was kind of like, hadn't really covered that too well. But when I went to Vic Uni to be interviewed, something that I missed out telling you about my childhood was that I'd gone on exchange to Sweden as a 15-year-old as well. So it must have been, I can't remember now if that was before or after my horse riding, but I've put the same year in there, so I'll go with it. But I'd spent 6 months living in Sweden and having to learn Swedish. And when I got into the Vic Uni interview, they were really interested in that ability to go overseas and travel and learn and be adventurous. And that got me into Vic Uni Osteo. So, so I suppose we were out at Vic Uni in St Albans, and we had Peter Gimmons and Paul Orick as our basic osteo lecturers. And they were obviously really experienced and really passionate guys, and they did most of the teaching in the first year. We did some of our science we did with nursing students and other courses like that. But then after a year, we got moved into the city campus, which was obviously a lot easier for people. Some of my friends that came over from the eastern suburbs were travelling 3 hours a day on public transport to get out to the west, which I'm not sure what it was like in your course in Sydney, but could have been quite similar. So we were out in this kind of barren, I think it had been like almost like a TAFE, and Vic Uni was almost like, at that point, the western suburbs TAFEs bringing in international business courses and things like that. And so they'd brought osteopathy in. I think the best thing was that we didn't have a student clinic at the start, so we had to learn from the osteopaths who were qualified, and they got fairly recent grad osteos in to run the student clinic, and we learnt from them. So we didn't have student buddies. We had people like Mick Kelly and Bruce Duncan, Glenn Bales, Paula Perrin. They were really good osteos, Linda Walsh, really good osteos who were working in the student clinic, and we were learning from them.
Yeah. And so, I guess, what was it like in terms of, I mean, the practice that you, well, not the practice, sorry, the teaching that you were exposed to from, I guess, Peter Gibbons and Paul Oric, was that more like, would they come in and say, look, they obviously teach you the content, but would they kind of salt and pepper that with, I saw a patient today and this is what happened, and these are the results I'm getting, and I wonder why this is happening, and I wonder why that's happening. Did that kind of, kind of conversation, was that peppered through your experience in the first, I guess, 6 months
I
of
could be wrong
osteopathy
here, but I
education?
don't think either of them were actually working as osteopaths while they were running the course. I think the course was a big enough
Right.
load. I think they'd both moved to Melbourne to teach the course and to start the course up. They did obviously have a wealth of experience, so they had stories of patients that they'd treated. But I would say, actually, from
Yes.
my own experience, that the course was, I could almost say, dry in the first couple of years. And it was basically a really good science course. I remember being told
Right.
after, about I found the first year really challenging, moving out of home and having to study and then get really good grades as well. And it was pretty daunting. And I
So,
remember being told that if I didn't improve my grades, I wouldn't make it as an osteo. And I thought I was working as hard as I could, but obviously I just had to work out a little bit harder.
yeah. Okay, so what really then hooked you? I mean, as a student, it's kind of, you've made this big jump from country Victoria into what you think is the city, but it's the western suburbs of Melbourne.
Yep.
What did you, what, I guess, what hooked you? Like, as a student, did you get hooked and you go, oh, I love this, this is what I want to do? Because, I mean, as a young person, I remember myself, you don't really know what you want to do, and it just takes something to drive a bit of passion into you and give you a bit of a kick up the backside to kind of go, yeah,
Yeah.
this is it. This makes sense. I know this is going to be something for me. What was that for you? Like, was it something that Paul and Peter kind of talked to you about? Was it an experience you had maybe further on in the course? Was
Yeah.
it maybe when you started getting your hands on people in the clinic, in the student clinic? When was that moment for you that you went, aha, this is for me, this is osteopathy, I love this?
Definitely the hands-on approach, and although I hadn't had a lot of exposure to osteo, I'd seen myotherapists and chiros and physios and other massage therapists, and just the way, I think it was that really basic kind of articulation that really, I remember first year uni, and we had to get really good at joint articulation. And as a kid, I also played piano, and I remember watching people articulating the lumbar spine side lying. And as their hands were going up and down the body, I was thinking, wow, it's almost like music. It looks really, just rhythmical. And I thought that as a basis is a really good technique. And I think, some students that come through and can do really good articulation and really good joint feel, it's just something that a lot of other therapists don't put a lot of time into. But obviously, that's one of those beautiful things that's a combination of diagnosis and palpation, getting close to a patient, and then you can also use it as a treatment as well. So I think that was good. But I
Yeah,
think also
definitely.
there's just a passion. There's a passion. Obviously, if you've got other professions telling you that osteopathy is what they would have done, or that they read osteopathic texts, you just think, what is this? And you just hear it in osteopaths' voices. It's just something that you pick up, and they plant little seeds. I remember Paul Oric, and so he's done a lot more study now. I was at uni, in the late 90s. And I remember Paul Oric saying that, and when he did his masters, he would do a masters just on the psoas muscle. I remember, the way we would learn anatomy, and you might learn that the biceps, flexes the elbow, but then you learn about the psoas, and the psoas muscle, that in itself has always fascinated me, that it's a lumbar spine stabilizer. And you think, what an amazing thing that there's a muscle that's called a lumbar spine stabilizer. And it must have a pretty important role, and we're learning how to treat it. And then I know people like Mick Kelly. I remember Mick Kelly, he was one of our clinicians, but when we didn't have students, obviously they just taught us. When we didn't have patients, they just taught us. And I remember him saying to us, some of you will become osteopaths and all of you will be musculoskeletal therapists. And, those little seeds,
I was just bringing that up. Yeah.
Yeah. Yeah.
I was just bringing that up on my phone because we had that conversation a while ago, and you, I think we were talking about the Top Gun cast of osteopathy, and and you mentioned Mick Kelly as saying that to you, as saying that a lot of you will become musculoskeletal practitioners, but only a few of you would become osteopaths.
Yeah. I just remember I lectured once at Mick Kelly had a conference in the snow at Mount Hotham, and he introduced me as a first-class osteopath. Still can't say their name. First-class osteopath, because I was in the first class of VU. So I thought, that's a pretty good title. Right. So you're only a second-class osteo, Sammy.
Well, that's right. I'm always going to be second class. So you can't change time. And so, tell me what that means for you when Mick Kelly says that. When he says, all of you will become musculoskeletal practitioners, but only a few of you will become osteopaths. What do you take from that? What does that mean to you? Like, what does that tell you about what he's trying to say?
It's just one of those many seeds that at the time you think, I don't know what that means. I had no idea. I was so young. I graduated at 23 as an osteo, so I was learning all of this at such a young age. And you just put these little seeds somewhere in the back of your mind and they just grow. And at the time you think, I have no idea what he's talking about at all. And I suppose the other thing was that, we obviously had to delve into Dr. Still's work. And I think even to this day, my most passionate aspect of osteopathy would be reading and rereading what Dr. Still wrote and trying to make sense of it. And I think one thing that really frustrates me is when people kind of don't understand Dr. Still or think that maybe, we need to rethink what he taught us. When I think that you have to understand when he was doing what he was doing, what his background was, the suffering that he went through. I love telling patients the suffering story of Dr. Still and the fact that he just had a moment where he realised that health is a natural state, and he'd come from this place of loss and, really looked into this model that he called osteopathy. And I think, that alone, just thinking about the person who actually started our profession and the fact that this profession is still actually really strong this many years later, I think it just says so much.
Yeah, well, there's no getting around suffering. I mean, suffering is part of human nature. We're all going to suffer in one way or another. He's taken that suffering, I guess, and has turned it into something that's still around today, and that's got to mean something. So I guess if you're gonna shit on his work, and that's the nice way to say it, because I've heard the same thing. So if you're gonna shit on that, then you're not going to get whatever you should be getting out of it. And there's a lot there. I mean, it's like we tend to sit on our high horse and think that we've got all this technology now, we understand all this thing, but all that information has been passed down to you. It's like there hasn't been an original idea really since probably a good 100 years ago, I think, in terms of medicine. An original idea is very, very rare to come by, and the fact that he had an original idea, or at least, I think osteopathy's been around in practice for way before Dr. Still, but he kind of put it together. He put the philosophy together and turned it into practice, into a coherent way. And I guess to be able to do that after you've gone through that kind of suffering says a lot about suffering, and says a lot about what he's actually been able to achieve. And so you graduated, I guess if you started in 98, you would have graduated by 2003, is that correct?
I graduated in 98, yeah. So I graduated
you graduated in 98, sorry. Graduated in 98, and so 1998 you graduate out in the big bad world of practice. Tell us about that. Where did you begin your early career, and what are some of the lessons that you draw from that today?
One of the other people who really influenced me at uni was Andrew Broad, and he was a doctor. So he was a GP that came in and taught us some medical diagnosis subjects. And he was just the funniest guy, and he just made understanding basic medical diagnosis really easy. And he had a practice in the inner east of Melbourne in Kew. And so when I graduated, I'd gotten to know him quite well, and I asked him if he would consider renting a room to an osteopath. And he said that he wouldn't, but he said he'd put a good word in to Q Osteo Clinic. And Dave Parker and Paula Perrin were running that. And so I applied for a job there, as did quite a few other people. And I was lucky enough to get it. So not sure if Andrew put in a good word.
Right, so let me get this right. The doctor that, what was his name, the doctor that you mentioned?
Andrew Broad, he was a GP. Yeah,
Andrew Broad. Right, so he was a GP and he came in and he taught you guys medical diagnosis at university. And then he wouldn't release you a room, or he couldn't release you, like he had no room for you?
He just had a really busy GP clinic in Kew, really popular, and he just said the rental that I charge GPs is way above what you want to pay. But going back to him, I think, as you introduced me before, that I really like to talk about the disease model of medicine and the health model of medicine. And Andrew Broad was one of those really wonderful GPs who was just so knowledgeable, but he also understood holism. And when he taught us medical diagnosis, I remember he said that medical diagnosis means that people have to fit in a little box of symptoms. And if they can fit in that box of symptoms, medicine can treat them really well. He basically drew a box on the whiteboard at the time and then said, you guys can treat everything outside the box. Everything we can't put in a box, you'll be able to treat. And so he really knew what we could do. And I was really lucky because having that relationship with him, and I'm sure he was a smart guy and he sent patients all over to many osteopathic clinics, but he'd send you a patient and he'd just write really easy, he'd write, he'd send you an x-ray of someone's shoulder and he'd say, oh, this lady's shoulder's not working, those kinds of things. And so I stayed in touch with him for probably a good 10 years of my the early days of my career, and he sent me some interesting patients. Actually, I've got a funny one actually. He sent me a lady. Did he send me her or did she just come in? But I had a lady with this really funny bump on the front of her knee. And it just did not feel normal. I had no idea what it was. And so I sent her off to Andrew and he did an x-ray. And then he called me and he said, a screw from a knee replacement. What am I trying to say? You know what I'm trying to say. ACL repair or something like that.
A reconstruction.
Reconstruction had actually worked its way around to the front of the knee. And she was only, 40. And, that's amazing, isn't it? And so, he just rang me and told me this is what it was. So it was a funny diagnosis.
Yeah, right. Well, I guess he would have had to contact the surgeon that did that and get things fixed up for her. Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show. And so you ended up working with another osteopath on the recommendation of the GP that taught you, medical diagnosis. And tell us about that experience. Your first, say, two or 3 years in practice. What was that like? What were you doing as a practitioner there? How were you treating? And I guess tell us about your experience.
Yeah, so I worked with David Parker and Paula Perrin in Kew, really great people and great role models. And Dave was, at the time, he'd been the president of the Victorian branch of Osteo Australia, and he was teaching HVLA at RMIT, and he was treating lots of really direct and lots of big sporting kind of guys. And then Paula Perrin was treating more in the cranial or indirect model, and she was treating a lot of babies. She'd brought into the practice from Belinda Coulton, who'd been one of the original SCTF teachers. So it was such a diverse practice, and you had to be able to do anything, basically. So one thing that I learned from combining the indirect model or the cranial model, I found that I could really relax people by using that model. And then so with someone with really, someone who just walked out of the gym and walked into my room and they were twice my size and had a lot of muscle tension, I do a lot of indirect stuff. And then at the end, I just pretty much do a heap of MET, HVLA. And it made my life really easy. But I spent a lot of time observing Dave and Paula in those early days.
Yeah, right. And I guess your training pretty much happened on site in terms of indirect. I mean, you just kind of learnt off the practitioner that was there.
No, I actually I made a big investment in that. When I was at uni, one of my clinical tutors was Linda Walsh, and she was working for the SCTF at the time, and she taught us a lot in student clinics.
That's the Sutherland Cranial.
Yeah, Sutherland Cranial Teaching
Foundation.
Foundation.
Just to clarify, SCTF, Sutherland Cranial Teaching Foundation.
Yeah, so we were very lucky at Vic Uni, and I probably should not forget this, that we got to do a whole year of cranial. We were taught by Dion Kulak and Leonie Alsop were the people who taught us, and we had that for a whole year. So, you either got it or you didn't in that year. You knew if you liked it or not, definitely. And then I was lucky enough to have Linda Walsh in a clinic as well, so I was getting some good one-on-one tuition as well. But then when I left uni and knowing that I really wanted to learn this model and knowing that it wasn't actually easy to learn, I did fundamental courses at SCTF for the first 3 years out. So I always laugh when students complain about the price of courses or the time taken at a clinic, because back then it was a 5-day course, and I think it cost $3,500. I could be wrong, but it was quite an investment.
Yeah.
And I just made myself do it.
That's a lot of money in those days.
It was a lot of money, but I suppose, the environment of Melbourne 25 years ago was there were a few big clinics that were set up, and they were taking on associates, but they were pretty full. And osteopathy wasn't that popular yet in Melbourne. So there was actually, compared to now where it's really saturated with osteopaths, there weren't many around. So there weren't that many people to go and have mentoring from.
Yeah.
You either went out on your own, which a lot of my friends did, or you did what I did and you worked in a clinic and then paid to do courses.
Yeah, right. Okay, so tell us about your, your evolution as a practitioner, being from, say, an early career graduate to somebody with a little bit more experience, did you change the way you started to practice? Tell us how you got your flow. I mean, we talk about this with other practitioners about the flow of treatment. When did that develop? When did you start getting a lot more comfortable in your skin, kind of more comfortable in your own treatment, and kind of, just having that confidence that anyone that can walk through the door, you'll at least be able to help them. If you can't help them, you'll at least direct them in the right way. Like, when did that confidence really start to come through?
People tell me that I had that straight away. And so patients tell me that I had that straight away. So I'm still treating people that I treated in my first year out, 25 years, and they're really proud of it. And whenever they say it in the waiting room, they say, I've known Elissa 25 years. I say, yeah, that's because you're not better yet. So, you still keep coming all this time. So I really do know the secret actually was that I was 23. I had a little bit of worldly experience. I think I thought I knew more than I did at the time. When you're in your early 20s and you know everything and you realize later that you knew nothing. But I remember, people would come in, and this is inner city Melbourne. This is a high socioeconomic area. I didn't grow up in a high socioeconomic area. And these people had a lot of money and they were, very clever and really clever business people. And they'd tell me all of these things that were going on in their lives, as well as that they had pain. And what I used to do was sit and listen to them. So I would make a point of really listening to them. Like, I suppose active listening is what it's called now. And in my mind, I would be thinking, what are the 3 things that I can do for this person now? What are the 3 things that I can either reflect back at them, do for them, or encourage them, something like that. And I remember that, by the end of each consultation, I would have at least reflected something to them that they'd said to me. I just think, what was the most important thing they said? And I'd probably say it back to them at the end. And they would think that I'd solved their problems. But all I'd done was kind of just sift through all of their, their mind mess and kind of just, I suppose it's, when you're treating someone, and this is easy in the indirect model when you're dealing with the primary respiratory mechanism and you're sitting and you're feeling the mechanism and it suddenly switches on and everything feels really clear and beautiful and calm. Well, that kind of happens in language as well, and people are just chattering away and all of a sudden they just say one thing and it's kind of like a pin drops or something and you're like, whoa, that's important to them. And so even early on, I was just sitting there thinking I had no idea how to help somebody that was twice my age, but then could just kind of reflect back, I think this is really important to you. And I suppose that act of actually listening to them, they really needed that. I've got like a crazy example of, and it's crazy, I was, as I said, early 20s, and I remember a lady came in to see me once and she actually asked me if I thought she should have an affair. And I mean, I got married in my first year out of uni. I was married at 20, 23, 24, something like that. And yes, my 25th wedding anniversary this year. So, I'm like early married, young girl from the country. And this lady's asking me, she'd met this guy at some resort she'd gone to, and she was saying, she'd been married quite a while and should I have an affair? And I remember like just sitting there thinking, she's actually asking me this question.
What do I say?
Yeah, what do I
would you
do?
say? Like, what do I say?
Yeah, what do I say? And and I think it was actually gold accidentally, because I just said to her that I thought that, her marriage was real and she was living it, and that someone else that she'd met at a resort was probably not real, and would you trust them? I said, it just sounds like you're probably thinking about leaving something that's real for a fantasy. And I was like, probably cool to have a fantasy, but probably not great to live it. And I was so young to give that advice, but it's good advice, I think.
Yeah, it is. No, the grass is generally and mostly not greener on the other side. That's the general experience, I think, of most people.
So I think that's the
you
thing,
gave the
though.
right advice at a young age. That's what you talk about, the pin drop, right? Like, you have this conversation, things flow, and you probably walked out of that treatment room with a bit of a surreal experience, going, "What just happened?"
Yeah.
And I hope that I gave the right advice, but I think you did well then.
There's just a part of
Yeah.
osteopathy that's really addictive. It's actually addictive to me. It's just this that you've got a limited time in a room with someone and you'll get an outcome. Really, you'd have to be, I don't know, not even listening, not even talking, and not even moving to not get an outcome. You're spending that time,
Yeah.
someone's turned up and, they've turned up and they want change usually. And, you just sit and listen and you do a little bit of osteopathy. And for me, it's actually magic. And I still skip to work. My husband's really jealous. He's a wine salesman. You might think that's a good job, but he says that, the amount of passion that I have for my job after 25 years, he is jealous of me that I have that.
Well, you could just catch that up with a couple of bottles of wine, I guess.
It's true.
Now, speaking of your husband, I want to ask you this question. Tell us why he says that you're the soup Nazi of osteopaths. He said you mentioned once that your husband made the comment that you're and for people that don't understand the context, soup Nazi is a character reference from Seinfeld, which is a very popular, obviously, people don't live under a rock, very popular sitcom. But soup Nazi is a very popular character.
Yeah, it's not a very
Elissa,
politically correct thing to say, unfortunately, but it's from Seinfeld.
Well, it is what it is. I didn't make up the character; it's there, and apparently, Elissa's husband thinks that she's the equivalent of the soup Nazi within the osteopathic world. Tell us why that is, Elissa.
Well, he's employed, and I'm not, so we have that conversation quite a lot. That I'm my own boss and I get to make a lot of choices and decisions that you wouldn't if you had a boss. But I think, in terms of people coming to see me for treatment, very early on, guild insurers sent out a lawyer to talk to the Victorian branch of Osteo Australia because litigation was getting more common. And so this guy came out and gave a little talk and said that first of all, to reduce litigation, you needed to have good rapport. So if you could have a good rapport with someone, chances of getting sued were pretty small. But the other one was to choose not to treat. And so I will tell people I won't see you. I've got two really good examples. I've got when I had a really small business and a lady wanted me to have, she'd forgotten her appointment and I charged her a cancellation fee and she said she wouldn't pay because the dentist was sending out reminder text messages. And I said, well, my business isn't big enough to do that yet, so I'm not going to do that. So it's my common line that I say, if you'd like to see an osteopath who sends out text messages, I'll find you one. She turned up about a week later with a dozen roses and asked if I would see her, which was pretty good. But it's the other thing.
It makes it.
Yeah, I've had patients get angry. You go.
Sorry, it makes it easier when you're the only osteopath in the area, right? And you can get results. They'll come back and they'll come in with a bouquet of roses. Yeah.
Yeah, I wouldn't say that for Kew. There's always been quite a lot of osteos in around that area, but I think the other one. I don't handle angry people very well. I don't like angry people. I don't think I have to deal with them. But back when I used to answer the phone sometimes, and this is why my business partner Alana said that she came to work with me, that I had a guy who called up and he couldn't get an appointment for a few days. And there wasn't much I could do about it. I don't think I had kids. I think I was working pretty hard at the time and just couldn't fit him in. And then he started getting angry that he couldn't see me. And I said, well, now that you're angry, you definitely can't see me. I'm not going to see you. You'll have to find someone else. And because if someone's angry on the phone, imagine what they're going to do if you stuff up their payment or, you hurt them.
That's definitely a no soup for you moment.
Absolutely. It's, if they're already showing those signs. But it is my favourite thing to say. I've got another lady that, similar thing, she was angry because I was running late and I just had one of those days and I was running late and doing everything I could. And when she came in, she sat down, she was a new patient and she was angry and she told me off for running late. And I said, well, you don't have to see me. You can leave right now. I don't need to see you. don't be angry, just leave. And she didn't even want to leave. I couldn't believe it. She said, no, I want my treatment and I'm not going to leave. And I actually said, but I will send you to someone who runs on time. If they've got a problem with my business model, they can go and find someone who works in the model that they choose. But I've been in, I suppose even when I wasn't that experienced in business, I just knew that I had a sense of control over those kinds of things, of how I wanted to work, the hours I wanted to work, and the techniques I wanted to choose, and I had to be able to choose them.
Yeah, I had a conversation last week or a couple of weeks ago with Jess Harvey, and she runs the burnout recovery program. She's an osteopath up in Queensland, and she talked about I guess, you know, how osteopaths really care. They really care, and they're very genuine, very compassionate. But I think sometimes we can take that a bit too far and let people get away with things, and kind of we lose control of our own time, our own appointment book, our own, I guess, what we prefer to do, because ultimately it's a free market and people are free to choose where they go, but also businesses and practitioners are free to choose on how they practice. And there's nothing wrong with that. And you'll find the person that's right for you, but to try and, I guess, make a patient, like we know this as osteopath, to try to make a patient fit into your model when it may not be the right model for them is a disaster for the patient. But on the flip side, for a patient to make the osteopath fit into what they want is not a good recipe for success either. You know, if there's something that really like irks you about your therapist, then it's easy to go and find another therapist, you know. But if you go and find another therapist and you're not happy with that service, and you come back and you go, well, you know, it's like, well, you got to put up with some things, you know. You know, a patient, like a practitioner like you might run a little bit late. You might be 10, 15 minutes late, and the patient's not happy about it. Well, okay, well, you got to, something's got to give. Yeah. You know, do you want the treatment or do you want to complain about being late? You know, what is it that you're after? So if you want the treatment, just wait for the treatment, I guess. You know, we no one likes to be late. No one sits there and sips a cup of coffee while patients are stacking up in the waiting room. It's not like we sit there and just have a giggle and go, oh, make this person wait a bit longer. Like, it doesn't work that way. No. People generally, if you're running late, then, you know, you're really rushing to get back on time. Yeah. And 99% of your patients have empathy for that. I think they understand. Yeah. And there might be the 0.5% that have just probably had a bad day. You know, they probably just had a bad day. But even if they've had a bad day, that gives them no right to kind of put their little bad day onto your day, because you're having a bad day too. And so let's all just chill out and get along, get your treatment, feel better and go home.
Yeah. One thing that I think about osteopathy as well is there's an intimacy to it. There's, I think we really connect to our patients. And I've been really lucky to travel to America with the Rule of the Artery group. I went over there. And watching American osteopaths work, they're even more kind of connected to their patients than us. They have, like, their arms are just so wrapped around people, and their touch is really even more genuine. I think Australian osteopaths are a little bit conservative in that way. And so I think we've got to acknowledge to ourselves that there is a level of vulnerability. And so, you know, we've got to keep up those strong boundaries. And it's funny how even having really strong boundaries, I still sometimes have patients who really try to push through the boundaries. But I think there was something else I wanted to say about, what was it? Well, I think the other really important seed that I learned early on was not to be afraid of negative feedback, or what you might perceive as negative feedback. And I think, you know, when a patient comes in and they haven't got the results they expect, or even the results you expect, I love taking that head on and using it as a learning moment for both of us. But I will, now that I'm experienced, or it probably happened also quite early on, people would come in and they'd think that I was going to be disappointed or worried, or, you know, that if they didn't get the results they wanted and they were still in pain. And so really quickly I learnt just to say, hey, this is good. This is good information, you know, and I'd be so interested in why they hadn't improved or what had happened, and just getting their story and really empathizing with them. And understanding them. And by the end of, that little awkward conversation of, I'm not getting any better, you haven't made a difference, they know that you care. And so they know that you're a team and you're going to get there eventually. And I think that's also kind of a vulnerable thing for a practitioner. I don't think other professions really have that same kind of team approach. With the
Yeah,
patient.
you're right. There is an intimacy to it. Yeah, there's an intimacy to it. There has to be vulnerability there. You've got to put yourself out there because, you're backing yourself into a working diagnosis, right? And you're really backing yourself. And if you're a confident practitioner, your speech is making that pretty evident as well. And so if things don't work out the way you plan for them to work out, it can be a little bit of a point where it could leave you a little bit down, right? But I think the key is to be confident in that you're going to help them, right? Not so much as in like, this is a diagnosis, I'm 1,000% sure this is what it is, but the confidence has to come from a place of genuine care and authenticity. And if they see that you genuinely care and you go out of your way and you're asking questions, not just about their condition, but about them as a person, that really shows that you're interested. And when I say them as a person, it's important that you kind of weave things into conversation about either their family life or their work life or their social life, because that'll tell you things. It'll tell you things that you need to know about their condition. It's not about you being nosy. It's not about you being, trying to get things on people. It's good to understand that they've got, a 6-year-old, a 4-year-old and a 2-year-old, because that's a level of stress that, a mother has to go through, that by the end of the day, her sympathetics are just ramped up. And there's no wonder why she's waking up with neck pain in the morning, right? Yeah. And so that's something you need to understand. So when you ask, how are the kids, it's not like, that's not a personal question. That's an important question that you ask, When you ask a young person about their traveling, about their adventures when they're traveling, tell us about what happened when you went to Sweden. Tell us about what happened when you went to... Things will come up in that'll give you insights.
Yeah, well, I had a patient a little while ago, and I've known her for a good 15 years, and she came in with a new kind of pain, a new kind of thoracic pain. And I know she's been caring for her elderly parents and living with them most of the week, and then she had this particular pain, and I couldn't figure it out. I treated her once, and I thought, yep, she normally resolves. Even if I don't think she will resolve, she normally feels a lot better, and I don't see her for another few months. But she came in a couple of weeks later. She has to drive from the country to see me. And it wasn't better. And I was just like treating and trying to figure it out and talking to her about it. And then right at the end, I just said something like, this strain sometimes happens when people have either just bought a new couch, which I knew she hadn't done, or just got a new car. And she said, oh, I got a new car a month ago. And I was like, There we go. And it was like right at the end. The treatment had been effective enough, but the penny dropping of her knowing what the cause was and knowing what to do about it, that actually made such a big difference. It was like you could feel, obviously I'm, and probably all osteopaths are, but you can kind of get a sense of not just the patient, but the energy in the room. And it's like someone's kind of opened a window and let out all the stress of, why have I got this pain? Am I going to be able to look after my parents if I'm in pain? And life's not as fun anymore. And then she realized it was the new car. And then it was like, well, good, because that kind of postural tension from changing your car, it can take a little while, particularly when you're driving, to and from the city to the country. But at least we knew what had caused it then. And that's pretty important.
Yeah, definitely. No, that's a great takeaway. The little cues that you pick up from patients and the things that you can help them with just to transform their energy in the room can make the biggest difference to the outcome. It's not just about the physical side of things. I want to ask you. You mentioned earlier about how you invested a lot of money into your development and learning about new things and courses and things like that. Tell us about, the experience that you've had, especially, or the learning I guess you've done, especially in pediatrics and women's health. Can you give us an insight as to the education there? And then how did you go about, I guess, expanding that into practice? You know, like people do courses, they learn about things. How long did that take you to really make it work into your practice?
I have to really thank Linda Welsh for this, because when I graduated, she'd been my clinician in my 4th and 5th years, and then she was getting married in my first year of practice, and she asked me to locum at her clinic, and so she had it all set up really well. She was only going for like a 2-week honeymoon, but one of the patients, and I think I had done maybe one SCTF course, or maybe I hadn't even. But one of the patients was a really tiny baby. Like, you know, when you're 23, I hadn't held many babies, and this baby was just tiny and had been crying and unsettled, and I didn't really know what to do. And Linda hadn't prepared me at all. And so I basically put my hands under the sacrum for a while, put my hands under the head for a while, and what I felt then, I would not know. I really wouldn't have known. But the baby came in unsettled and left asleep. And I actually watched as the mum, because I could see the car park from the window, and I watched the mum put the baby in the car seat, and the baby was still asleep. And then I was like, oh my gosh, is the baby going to wake up? Like, I was so, I had no idea what I was doing. And so I was luckily there the next week, and the baby came back in, and it had been a really successful treatment. And to this day, I have never settled a baby ever the way I settled that baby by just sitting there and, I suppose, hands in the right place, just waiting to feel anything, and probably not imposing the need to change it. Probably as you get a little bit more experience in the indirect stuff, you probably start kind of pushing fluids around or trying to achieve more. So it's very interesting on that one. But I would say, well, I'll talk a little bit about tongue tie, because I think that's a good example of how, as an osteopath, I would say I'm a generalist osteopath. I would treat anybody. And I think my oldest is a 96-year-old so far. But
that was my next question to you anyway, about tongue tie. Can you explain to us some... Yeah, can you explain to us some of the considerations, I guess, that you would think about? Tell us about your thought process with tongue tie.
I think the story's better because I was treating a lactation consultant who I knew really well, and she just came in one day, and she was a very experienced lactation consultant, but she came in for her own treatment one day and asked me what I thought about tongue tie. And I said, well, as an osteopath, the tongue is a midline structure, so it's going to be important. And then I just started talking about midline structures and diaphragms to this lactation consultant. And she said, oh, would you come and speak about that to our, I think she just called it a meeting. I'm sure she called it a meeting. Anyway, it ended up being an international symposium. So I'd already said yes. So then I had to write a talk for an international symposium on tongue tie. And I did. I basically was able to speak about the osteopathic considerations, and I spoke a lot about diaphragms and midlines, points of balance, and the anatomy. And actually, I think if there's a take-home about tongue tie, and the grey area is, do we get a frenectomy? Do we snip it with scissors? Do we laser it? What do we put babies through? And I think when they're really tiny, there's a great dentist in Melbourne, Dr. Kestenberg. All the Melburnians will know him. He's one of the old guys that's done this forever. He'll actually send a baby to an osteopath when he thinks the baby's nervous system isn't mature enough to handle the laser frenectomy,
right?
Which can be pretty traumatizing because they don't use an anesthetic. The little baby's taken away from the parents. They have this procedure that takes, maybe 30 seconds. The most important thing an osteopath can do there is to encourage good function. So I hear people talk about that they get a baby's tongue snipped or lasered, and then the fibers reattach. Now, I don't think that the fibers can reattach, but I think that if you've got a really deep posterior tongue tie, and then somebody takes the outer layers away with a snip or a laser, and then the function changes. I think sometimes the tongue can protrude more, and then you might see more of these fibers protruding as well. And so then people will think, oh, it's reattached. But I think that what I always tell parents is whether you're getting a snip or a laser, what we have to do is change the function. If we can use that little moment of an opportunity for better function, then the function will change and the structure will change. So that's that really obvious
So tell us how you do that, Elissa. Tell us how you do that. Like, what do you actually? Yeah, what would you be doing?
Yeah, you've just got to really know about the biomechanics of sucking, and you've got to know that the baby's going to be using the cheeks and the tongue and the the jaw, and also you've got to use breathing mechanics. I think, a baby, so I learnt this from teaching at the International Symposium and listening to the surgeons. All of the pediatric surgeons know that if a baby has to choose between sucking milk or sucking air, they'll be breathing. They will never choose to drink over breathing air. So a baby that isn't sucking milk very well needs to breathe better. So any osteopath can work through the pelvis, all the way through the legs if you need to, any of those strains, all the way through the diaphragms, and definitely all the way through the neck and the tongue muscles to release whatever's holding back that function.
Right. So improving breathing obviously will then improve the sucking, and then that then has an effect on the function of the tongue.
Yeah.
And then obviously that's how you address the tongue tie.
I think that the work I do with babies and the work I've done with tongue tie and the work I've done with stress. So the other really great talk that I've done is one called Stress and the Mother-Baby Dyad. And that came about just by being on Facebook, and I was just chatting on Facebook with some manual therapists in Canada, and then one of their speakers dropped out of their lactation consultants conference last minute, and they said, could you be a body worker and talk at this conference? And I said, yeah, of course I can. And I just don't seem to say no to opportunities. And so then I thought, well, what will I quickly write a talk about that could make a difference here? And I thought, well, stressed mums is the thing that I see most. I see so many stressed mums, and if you've got a stressed mum, you've got a stressed baby. So I wrote a whole talk at this lactation consultants conference, and I was the international speaker from Australia, which made it kind of really romantic, even though I was in my lounge.
Sounds good.
It was amazing. And and people still listen to that now, and it was 2016 that I recorded that, and people are still buying it, which is really good.
Tell us then, I guess that...
Yeah, the basis of that talk, though, and what I think is really, really important about stress and mums and babies and dads and babies is that baby really needs to have the best parents they can have at the time. And so I noticed that a lot of people come in and they want to help the mum by looking after the baby. And I think the best thing you can do for a mum, if you get invited into a new mum's house, is go in and say, what do you need me to do so that you can connect to your baby? And one of the things I've learned from really good lactation consultants is something called a breastfeeding holiday. And mums can't believe they can have a breastfeeding holiday. But if your baby's not feeding and you want to breastfeed your baby, and you're thinking that you're going to have to put that baby on formula and you don't want to, then you can actually take that baby to bed and sit in bed and be looked after for as many days as you need to attach that baby to the breast, and just offer the baby the mum and reconnect and take out whatever stress is going on with the mum and or the dad and build that family unit. And I think, possibly the fact that I grew up with divorced parents, maybe that's brought that really home to me, and the fact that I've been able to raise two kids in a family and stay together as a family. It's such a blessing. And I get really heartbroken when I see families fall apart, because I don't know if this is appropriate or not, but someone was asking me the other day about when a family falls apart and the mum and dad can go off and find other partners, but the kids, they can't. Their parents have separated, their family's not there anymore. And I said, maybe we need to invent some kind of Tinder for for parents so that kids can say, well, these ones didn't get it right. Can I can I find another
Can
one?
I have a new set? Yeah.
Yeah.
I don't know if biology will allow that to happen. I think there's a connection there between parents and children. Look, my personal experience, I've got 3 children, and my wife is currently pregnant with our 4th. And she's due in December, so I think we're recording this in early November. So she's due in about 6 weeks.
Yeah.
And throughout this last, I guess, 6-7 years of having children, we've really learned that that the old saying that it takes a village to raise kids is so true. And part of the reason why that's so true is the support structure for the parents, where then they can actually have a good relationship and their relationship can last, because that's the hardest part of it. I guess the stress of kids usually puts a strain on relationships and some of them can't make it through that strain, and the kids end up suffering.
Yeah.
And I guess you're right. The best way
I'm the other end of the spectrum to you. My youngest daughter's just finishing year 12. She's doing year 12 exams just now. And my oldest one's 21 and lives away from home and is at uni. And so my husband and I have started dating again, which is good. Yeah.
Well, that's good. But I mean, that's happening, I think, because you went through those times, and you're a different couple now than what you were when you first got together, I'm sure. But it really takes that support structure for the mum. Like my wife's lucky she's got her mother-in-law and her mum, and just having them make a meal for us, for example, and having my wife just sit there with the baby and not worry about cooking or doing anything, and then having someone come over and helping her with chores and and I guess having that support structure there is really, and I know that not everybody affords that, not everybody has that.
Yeah.
But I guess as a community, if we can have something in place to support mums a little bit better, that will make the health of the baby so much better too. And that's my next question to you was, how can we support women, I guess, in those times, and mothers specifically? How can we tell us about your experience, I guess, with new mums, and then what is that experience that you've got? What lessons can you give to us on how to support them better in terms of practitioners? Like, we're practitioners. A new mum's coming to see us. She's got a newborn in a little carrier. What can we do to help? What kind of advice can we give? So maybe tell us about, what is the thing that we should be treating, one thing that we should be treating, really looking at, and then what is one thing that we should be advising on?
The one thing we should be treating is the autonomic tone. I think autonomic tone and the connection between the mum and the baby. So, for example, with breastfeeding attachment, I once treated a baby who had a tongue tie, but the only time we could get her to attach to the breast was in the treatment room when the autonomic tone was relaxed. I think it's something that it's another kind of sensory experience, but it's something I'm really aware of. I'm really, really aware of autonomic tone in people and all the different things they show when they're slightly more upright, when their face is slightly less expressive, when their vocal tone is slightly less expressive as well. And I think the way we treat this, though, the way we treat autonomic tone is a lot of understanding how to down-regulate people. So that starts straight away. I have a lot of patients who come in and sit down, new patients, they sit down, and just the way I say, how are you, or how can I help you, they start crying, because they know just from the one way I say that one sentence, they know that I'm going to help them. It's amazing. And just so many people cry in my room and then say, oh, I can't believe I'm crying. And I'm like, look, it's really common for people to cry. And I think that's the other thing, though. When I had my own baby and she cried a lot, my first baby cried a lot. And I read a book called The Aware Baby, and it was basically how parents don't have to stop babies crying. And I actually really listen to babies when they cry. So if I get a mum and a baby and everyone's stressed, babies will generally cry more. And I'll just sit and I'll listen to the baby cry, and I'll actually tell the mum a really good cry has many different sounds. It could be really loud. It can also be really soft. And I'll hold on to the baby's diaphragm and often their head. I often have them sitting so that they're one of my hands is holding the diaphragm at the front and the other one's holding the occiput at the back. And they'll be just kind of sitting over my hands. And I'll just feel them start to tummy breathe into my hand at whatever age they are. And I show the mum, this is a really good way to hold a baby. Or you can just hold a baby onto your tummy and tummy breathe. Now, they may not stop crying, but it's really relaxing. And so you just watch the mum and the baby down-regulate. And so there's so many ways osteopaths can help someone down-regulate. And I think it starts with the tone of your voice and the level of care you have, and then how you put your hands on them and how calm you are. And I think I've now, over years of time, developed a response where as soon as a baby starts crying, I just start down-regulating and being the most relaxed person in the room, wherever I am. I think it's a good skill.
Yeah, I'm quite fortunate. Like my clinics are probably a little bit different to yours. I've got a sports medicine clinic, right? So we treat, the way that we get to treat, I guess, mothers is that we treat them when they're active before they probably even get married. Then they go off and they get married, and then they continue to see us, and then they'll have children. And then because we've been treating them for so long, naturally when they have pains and aches postpartum or even through pregnancy, they'll come and see us as well. And one of the things that I've learned, and especially when you're treating, I guess, healthy mums, mums that have had natural births, there's no major issues, the baby's attaching, everything's going well, they're still going to have all these mechanical issues related with breastfeeding and with being up all night, not getting enough sleep, having to, I guess, obviously the postural changes from being pregnant, and then the body bouncing back from that real kind of laxity in ligaments to then everything's starting to kind of bounce back in.
Yeah.
They're going to have some aches and pains. And if you find that someone's generally quite healthy and they've gotten through their pregnancy really well, the best thing you can do to support that mum is to just deal with the thing that she's asked you to deal with. Don't get too involved in, talking about things that maybe what's going on with reflux and what are you feeding the baby and what are you doing there. It's she's coming in to see you. She's got this, T1 flexion that's just causing, the whole the shoulders caved in because she's breastfeeding, the pec's tight, everything, unwind all that stuff, treat it, correct the thoracics, have a look at the CT junction, and then, just help her out that way. Get rid of that kind of strain on that system. And people think that you've just done a small thing. You've done a big thing there. You don't need to. And so I know you've mentioned and you've talked about how you can support mums that are maybe either struggling with either attachment or having issues with the baby. But on the flip side, on the other end of that, when you have a healthy mum, you can still help them by just looking after your role is to help them just feel better and overcome some of the strains that they've accumulated. Yeah. Just fulfill that role, and that's the best way you can support them.
I think I get mum patients another way. I think I get mum and dad patients when they bring in their baby, and I meet them first with a baby, and then I always treat the mum, always give the mum a little bit of time. And then sometimes the dad's got some time as well, and I get to spend some time with the dad as well. So it's more like I'm meeting them with their baby, and then they end up being my patient as well.
Well, I love the different perspectives, how they're coming in through different channels as well, and there'll be different needs and it's like if you run a type of clinic that's geared towards that, you're going to see that. If you run my kind of clinic, you're going to see it, but you're going to see it on the other end, and you should still be prepared for it. And the beautiful thing about
I think what we're saying is just treat what's there. Just whatever's in your room that needs to be treated. And a really experienced practitioner will be looking at that. I've got a great example of that where one thing when people bring in their kids, I will usually say, can I look at the other kids as well? And parents often bring in the rowdy kid. And often it's the quiet kid that needs the treatment. So I remember one time that someone had brought in a brother and sister, and I treated the sister for something musculoskeletal, but I'd said, can I have a look at the little boy as well? And I treated the boy just for a few minutes, and I noticed he had a neck strain, some tension in his subocciput. And the next day the mum actually rang the clinic, and the little boy had been home, and then after dinner he'd said something like, it's not there anymore. And she said, what's not there? And he said, the pain in my head. And they didn't even know that he'd had headaches. And she rang the clinic to say thank you. And that was like 5 minutes after I treated the sister. And I didn't charge him for that one. It was just a little checkup. And it really made a difference.
Yeah, that's amazing. And can you imagine the difference that makes to the family dynamics? Because you got this little kid that's got a headache that's probably going off like a fuse at the first kind of little irritation that he gets. Then his sister's going to go off, and then the parents are going to get agitated. Just the flow-on effect of cortisol in that place, just by releasing that young child's little neck strain, you've unwound really a big problem in the family. It's amazing. And what I was going to get to, and what you talked about, is that we're seeing people from different angles. But the beautiful thing about osteopathy is that you take this philosophy and it applies in different ways. It's like you can kind of come from different angles, but the philosophy never changes and it works. It just works beautifully, right?
Yeah.
And so that's a really good example. That little chat that me and you have just had in the last probably 10 minutes, I think is a really good example for people that are listening on how the principles and the foundations of osteopathy can really help from different perspectives.
Yeah.
So that's
I
great.
think the easiest way in...
Yeah, go ahead.
I think the easiest way, and you touched on it before with breathing, I think that it's really easy for an osteopath. We're really good with ribs. We're known to be really good with ribs, as you say, really good with the thorax and really good with the pelvis. And all of those structures are involved in breathing. I mean, the tongue's involved with breathing as well. So we've got the whole body. And then when you think about what might be the primary respiratory mechanism, which is also a breathing rhythm, I think that anybody, any osteopath, first year student, anybody can have a look at anybody they see and figure out something that's in the way of them breathing really, really easily, or just enhancing the way they breathe. And I think the one other thing as an osteopath is osteopathy is not about recipes. And lately people are coming up with heaps of breathing techniques and they're all recipe based, like box breathing or Wim Hof breathing, and they're following recipes. And I'd love to write a recipe book that would help people to get optimal function. And we can't, because we're an N=1 modality. And so patients come in, and most of the time I'll give them a breathing exercise and then a really basic core stabilizing exercise. Something like standing from sitting, or, and then just breathing. If they're not moving rib 12, breathe lower down. If they're not moving rib 2, breathe with your hands on the clavicles. This kind of thing that patients can learn just by putting their hands on the part of their body that's not working very well and getting to know themselves better. I think, we just don't need... I think anybody can teach recipes about breathing, but I think osteopaths should be able to come up with really biomechanically sound breathing exercises for their patients.
Well, you've just touched on that, on what Mick Kelly said earlier about being a musculoskeletal therapist versus an osteopath. You've just highlighted that point. Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show. Now, you've been around since, I guess, you graduated in 98, and you've seen osteopathy really blow up and flourish in Victoria. Tell us what have been your observations over the last, say, 26 years of being an osteopath and seeing, because I mean that RMIT was there, I guess, before it was RMIT, it was a Phillip Institute. That was, I think, the first ever university-based osteopathy course in the world, which is a great achievement. But then came the VU course. And I think having those two courses in Victoria has really exploded and almost put an osteopath in every suburb
Yep.
in the state. And so, tell us about your observations on that. How do you think what's happened in the last 26 years? Can you give us your thoughts on that?
Yeah, well, it was hard to get patients when I graduated because people didn't know what osteopathy was. So now it's harder to get patients because everybody has an osteo already. So it's interesting that what I've seen is in my clinic. I mean, I'm glad that I became an osteopath when I did because I've worked in the same area and I've got a really good name for myself. But I think within that, I've had people come through my business, and I've literally had a couple of people come in, and in a couple of weeks, they're just seeing my overflow, and it just takes off for them. There's a really, I think one of the things that makes it, you don't like pointing out what I suppose I'm pointing out what I'm good at or what makes my clinic a point of difference. And I'm sure a lot of other people will have this as well, but it is actually the kindness and the consideration. And we've stayed small. We're just Alana and myself, and then an associate or two. We've got a Myo working there at the moment, but we don't have a receptionist, and we run it ourselves, and we just stay really local and really we really care about people. And I think honestly, when osteopaths come and try to work in our clinic, and if they don't have that same level of care, patients feel it straight away. And it's something that's really hard to teach. I mean, I think the way to teach it would be through observation and people actually learning it from us. But then we've just had a couple of associates that come through, and people just feel it and just see it, and they just connect straight away. And so all of our patients are happy to go to that person. But otherwise, what tends to happen in Melbourne is that patients can really practitioner shop. So they can really just go to the most experienced clinician, in the clinic. So they can go to my clinic, and then they can go to Julie Piper's clinic in Northcote, and then they can go to Dave Parker's clinic, and they just go to all of these different people with good reputations instead of trusting the brand of that clinic. And so I'm always trying to teach my patients that they can trust the brand. But if you get in an osteo who doesn't listen or doesn't do anything similar to you, or, one of my patients once saw an associate that just wasn't getting it, and they said, "Oh, that was literally a massage." And I thought, "Oh, damn it! I didn't think they were doing that. I thought they were actually doing osteopathy." So, not that patient is lost from the clinic, but the new associate hasn't made the most of the opportunity in the room with that patient. Yeah. I suppose the other thing at university level, and I'm not that close to it, but I can see that they're getting a lot of people through the universities. I've got friends that teach at university, so I don't want to kind of say anything offensive, but I think they've dropped the ATAR a lot. I don't really understand that. They've dropped it to maybe 65, something like that. And they're getting, 100 new grads a year. And I just think they're setting them up to fail a little bit, because you've got to be pretty clever. And my Year 12 daughter's just gotten an early offer to do nursing, and the ATAR for that's 65, and she's happy to do nursing. It's not about that for her. But if you think, osteopathy, when I wanted to do osteopathy, was a really high ATAR, and I think you actually really needed that ATAR to do all of the anatomy and physiology. And, you have to also be really dedicated to it.
Yeah, it's a title. I mean, high school, I guess. To get a good result in high school, I think you just have to work hard more so than having some natural gift at being smart. I remember being in high school and having this a guy that I did chemistry with, and I just had to work so hard to get it, but he just got it like that. Didn't even have to try. He went off and did something fancy with the Navy, was dismantling bombs with the Navy or something. He's a, Cameron, if you're out there, shout out to you. But he got chemistry. I really had to work hard, and I think what the HSC, or what the equivalent, I guess, in Victoria is, or whatever the model that you use, high school. You can work hard in high school and get a good result. And that's what we need. We need people to then go and work hard at osteopathy
Yeah.
because it's hard work. Learning physiology, learning anatomy, learning pathophysiology, pathology. They're not easy things to learn. They require time, effort, and repeated time and effort. And that's something that I guess high school will teach you, right? High school's not for everybody these days, but if you want to do osteopathy, I think you have to do well at high school. You at least have to put in an
You have
effort
to.
there.
I think high school teaches you how to learn. I think, and my older daughter's a brilliant student, much more clever than me, and what she learnt really early in high school was how to give each teacher what they wanted. So somehow she could just read people and she could just say, yep, this is exactly what that teacher wants and this what that teacher wants. And so she knew how to deliver information to people, and she's taken that. She's in third year uni and she's just absolutely brilliant. So I think it's that level of knowing how to present information to people, I suppose. You've obviously got to have the learning base to put it onto.
Yeah.
Yeah, but I suppose I'm
I
just a bit
spoke with,
concerned about
go,
what's
go
going to
ahead.
happen with all these graduates that are coming out, and I'm not seeing them. Before COVID, I was always mentoring students. RMIT would send me out someone, sometimes Vic Uni would send me out someone, and they'd spend a year. I'm not big enough to employ them as student practitioners, but they could come and observe with me, and it was considered part of their clinical experience. And that's not happening anymore. And I'm still friends with most of the people who observed with me because we got along so well and we spent so much time together.
Yeah, I guess that leads me on to on my next question. So you've seen osteopathy over the last 20 plus years. Moving forward into the future, how do you see the landscape of osteopathy, and what are some of the current and future challenges? Like, what do you think are some of the things that we need to be aware of, for the future?
I don't think we're going through anything new. I think osteopathy's gone through these challenges for its whole time. It's always had its you know, we've had some big critics that came through and changed university structure and took some of the really good techniques out. And look, I think when I go back to Vic Uni starting up, I think the premise of that was they actually wanted Vic Uni to be more scientific or more medically accepted. So we got a really good science degree, and then we did an undergraduate master's. Did you do that, Sammy, in yours? Did you do a research project?
Yeah, so we did. Yeah, we did undergraduate, and then we did. Our masters was research and clinic based. Usually, masters are
Yeah.
either one or the
Yeah.
other.
Yeah,
But
we were
our
the
masters
same.
was both. Yeah,
Yeah,
masters
and
was
I was thinking
research
about
and clinic
this.
based.
Yeah, I was thinking about this because I know. So I just did a survey of Victorian osteopaths and how they were treating pregnant women, and I hated it at the end, and I didn't keep it, which is crazy. Somebody asked me a little while later if I still had it so they could follow up on it. But what I did find surveying Victorian osteopaths was exactly what you said about pregnant women, that they weren't actually treating pregnant women as if they were pregnant women. They were just treating pregnant women as if they were women, and they were treating whatever came into the clinic. And I thought, as a student, that was amazing. I thought, well, that's fantastic. But I know another one of my friends at uni did a really good research project on testing the change in pressure under the abdomen. So she was getting some kind of pressure measuring device and putting it under tummies. And it was way back, before the core link and the core stability stuff had all come out. But she was testing how we could train people to use transversus abdominis properly and to actually get a change in pressure under the belly. It was really cool. So I think some of us did some really good projects. But what I was thinking when I was at uni was, I'm a student and I haven't been exposed to the industry enough. And imagine if they could pair students who had time to do the research with people who actually were really passionate and who could help them just a little bit, just to dip their finger in, even just to know what to study. Or, when you're talking about studies that are done on HVLA, but they're using second year physio students to do the techniques, then maybe that's where the profession could come together and we could do some of these projects with the right people teeing up. And and probably more students being mentored by people who really do care so much about what happens in the clinic.
Yeah. Research is such a hard one because, if you ask a student body to make up for the evidence gap, it puts a lot of pressure on students. That's not what a student is supposed to be doing. A student is supposed to be getting themselves ready to go out into practice, whether it's private practice or whatever's happening these days in terms of being in a aged care facility or some kind of other role that people are getting into. But I assume most people are getting to private practice upon graduation. You need to be ready for that. That's what university should be preparing you for, is to treat patients, to be able to consult and treat.
I kind of get that. I kind of get it, but I also see that when I was at uni, I happened to do statistics or reasoning and data at year 11, 12 maths. And then I did 3 years of stats to prepare for my undergrad masters. And I actually really knew statistics really well. And we also had a really good biomechanics lab at VU. And so some of the research coming out of there could be pretty good and is really good. But I just think that the students could just have a little bit more support from the profession. I know that every now and then I get reached out to, can you fill out this survey or can you do this? But imagine if we could get students coming out into our clinics maybe and gathering data from the actual clinical environment. And I think, I hear you talking about...
That's something more like you're talking about, more longitudinal studies where a student will map out what a practitioner's been doing and then have a look at some long-term data from that. That all goes. That's well. I don't disagree with that. I just think that the way that the evidence model's set up at the moment, with systematic reviews and randomized controlled trials being at the top of the food chain, unless you're doing those things, people aren't really going to pay attention. And to be able to do things like that, you need the university structure. You need to be able to... Most people that are doing PhDs and running RCTs and things like that, they are usually at a university, right? They're a member of a faculty, they're doing a PhD, they're whatever. And that's fine, that's good. But what we're doing is we're taking our master's students, we're putting the burden of research onto them. The quality of research is not going to be high because, like you said, there's no practitioner guiding them and giving them information and kind of trying to guide what they do. And so we've got this thing where we're pumping out some evidence, but it's not really great. It's poor. I think there needs to be a rethink of that and what we do with research. And what happens if you're a student, and let's say you enjoy research a little bit, like you kind of get it, you're doing biostatistics, you go, you know what, I don't mind this, I don't mind touching this. And then you go and you do your master's and you put into this research project where you've got to get over the line, and then your supervisor's telling you to do X, Y, Z. By the end of it, you hate research. You don't want to do it again, ever, right? And that's not good either. We're turning students off research, whereas if we let them go out there into the world, find a topic they're interested in, that they've treated, that they've seen, you know what, I've applied this treatment to this person, I've done it to this person and that person and that person, and there's something going on here that I'd like to look into. They'd go back into research because they haven't had a bad experience with it.
Yeah.
And so we don't want to turn students off research.
Yeah, I have to shout out to Lainey Cameron. She was my research supervisor at uni, and I'm still in touch with her now. Just love her. She's the loveliest person. And she's now an exercise physiologist and an osteopath, and she's also teaching at, I can't remember which, University of Southern Queensland. Sorry, Lainey, if I've got that wrong. But I've always talked to Lainey about wanting to do research and how I could do research and should I do a PhD. And so I've just gone back to uni. I'm doing a grad cert in mental health because I think that's really important in Melbourne post-COVID. And I just needed to add some structure into all of the chatting that I'm doing with people. And I'm only 2 weeks in and I've learnt so much already, which is amazing. I'm learning that mental health actually has that whole, when I'm calling it mental health, but like one of the things I'm learning is how we focus so much on the disease of mental illness instead of looking at how we can do mental health promotion. So I think osteopaths as mental health promoters is just amazing. But Lainey and my husband both agree that I shouldn't do a PhD because you don't earn any more money being a PhD osteopath in clinic, but but you could definitely do
No.
research projects. You could do really, really good research projects with your patients as an experienced osteopath. And I think probably that's where I'm headed one day.
Yeah, that's good. But hopefully that you haven't lost the passion for it, and that's what we need. We need people who have probably been practicing for 20 years plus to kind of want to take their career into that next direction. And if research is that direction, they're the people who really want to be able to provide that evidence base for us.
The reason I got to, I just want to quickly say this, the reason I got to doing
Yeah.
this grad cert in mental health is I've been looking at Osteo Australia, and they have their pathways to advanced practice, and I'm like, I don't want to be an advanced practice peds or sports or rehab, or I'm just not, none of those topics have really got my attention. But I think
Yeah.
osteopaths as trauma, as qualified or experienced advanced practice trauma informed practitioners with mental health background, for me that's a really holistic add-on that I, because then everybody has mental health elements that can be addressed. So I think for me that's where I'm headed.
Yeah, I spoke to Fiona Peat a few weeks back. I think that episode's aired since, and
I saw that
she's
one.
in a similar position. Yeah, she spends a lot of time talking to patients and I guess helping them through trauma that isn't just physical. And I guess you're right. There needs to be some kind of formal training there, and hopefully a pathway that's recognised. But
Well, if I can ask
I
you a
guess there's
question,
enough
Sammy,
practitioners.
there's something,
Yeah.
we talk about tissue level stuff, and I'm kind of thinking you do some indirect, you do a lot of direct stuff and some indirect stuff, do you?
I do mostly direct, but I do some
Mostly direct.
indirect.
So what does
Yeah, I
it
do
feel
the
like?
indirect stuff is more like, yeah, go ahead.
What does it feel like to you when a patient walks in and a part of their presentation has an element of shock? How do you pick that up in the
Oh,
tissues?
the tissues are like rocks,
Yeah,
you
yeah,
know.
yeah.
They're like rocks. And whether you've had experience in, I guess, speaking to people like that, or you haven't, or if that's part of your treatment, I should say, at the very least, if you're palpating tissues, you'll pick that up, and I'll talk to you. I mean, this is the first discussion I've ever had with you, Elissa, and you
Yeah,
would
yeah,
agree that if you see a patient in shock, their tissues are just like a rock, right?
yeah.
And if I spoke to another 5 different osteopaths that have had experience in it, they'll tell you the same thing.
Yeah.
You know,
Some patients who have shock also have an overwhelm and might then have low tone as well. So, I think
yeah,
there's, different elements, but I think as osteopaths, meeting people at the tissue level or meeting them at the story level, I think we can just take it that little bit further. And I just see where, particularly Melbourne COVID and the trauma that happened with those huge lockdowns, and just the amount of trauma and stress. I was also treating some, hospital workers during that time. One of my favorite patients, we're not meant to have favorites, but she's an intensive care nurse at one of the biggest trauma hospitals in Melbourne, and she would just walk in during COVID and just lie on the table and cry. She was just right there at the front line. So, just the amount that I've learnt from that, and the amount that I know we could go a little bit further into really supporting people with trauma.
yeah, you're not wrong, and a lot of that also comes back to your own life experience. I guess it's really hard to be. I mean, you think back at yourself when you first graduated at 23. It's really hard to have those conversations with people and to try to unpack some things. But as you get more life experience, the neuro-emotional stuff becomes a lot more evident to you because you've seen it in your own body too. You've experienced it. Most people that get to the age of 40 have usually had some kind of trauma happen to them, or some kind of life experience that's really affected them, and they've seen the physiological change in their own body, and so they really start to understand that. But when you're in your early 20s and you're out there and you kind of just nothing can hurt you kind of mentality, it's really hard to understand that side of it, and then it becomes hard to apply that to your patients. So,
Yeah.
like I
Well,
said, I spoke to Fiona Peat a few weeks back, and she mentioned the same thing, that life
yeah.
experience was a big thing for her.
Yeah.
And so you're
If
saying the
any
same
new
thing today.
grads, yeah, if any new grads are listening, then as a new grad who went through this, I think if you sit and you listen for a good 2 minutes, 2 to 3 minutes, just sit and listen calmly to whatever happens when people ramp up, you will get so much out of it. And I don't think you have to be too wise to do that or too experienced. And I don't think you have to empathize with people or know their story. I think you can be compassionate and calm and kind and educated. And I think if you sit in that, even as a 23-year-old, you've got an education that the patient doesn't have. You know more about biomechanics usually than that patient. And you'll find something within them that you can help. And even if it's one thing, it'll be huge.
Yeah, you'll find an entry point. There'll be an entry point there. Just got to find that entry point. Yeah, okay. Elissa, I want to thank you for the conversation tonight. We've done a good, I think we've had a great chat.
Thanks, Sammy.
And so, it's been great. We'll probably do a round two sometime down the future.
That sounds fun.
Yeah, thank you for your time tonight. Now, I know everybody's going to be wondering, but yes, the merchandise is here, right? Make osteopathy great again. There's a little 1874 there. So if you've all been wondering, this is the merchandise, and if you like it, leave a comment, I guess, on whichever platform you're listening to, and we'll see if these things take off. We can help people get some onto their backs. Elissa, thank you so much. Stay on the line with me, but for everybody else, thank you for your attention in this episode, and I will catch you on the next episode.